Hi, and good evening, everyone. I'm Dr. Josephine McCullagh, and I'm a consultant clinical scientist working in blood transfusion. And I'm going to talk to you today on the topic of right blood, right patient, molecular techniques to better match blood. Next slide, please. So when you donate a unit of blood, normally it's collected into a single bag, which is known as a whole blood donation. However, most patients don't need all of the components all at once. And so, to make it more useful and specific for individual patient need, this whole blood donation is separated into its individual components. And these are red cells, platelets, and plasma. And these will be used for different transfusion treatments for different patients. So, for the purposes of today's talk, I'm going to concentrate mainly on red cells. So, red cell transfusions are required for several reasons. And the main reasons are to replace blood that is lost during bleeding. And that can be during surgery, following childbirth, or after a traumatic event, such as a road traffic accident. Other groups of patients rely on regular blood transfusions to support with symptoms associated with chronic anemia. And these patients include patients who are suffering from cancer and going through treatment that prevents them from producing their own red cells. And then patients with genetic conditions such as sickle cell disease and thalassemia. But there are many more, as you can see from this image on that red cell. You can see all of those markers donating, depicting the different antigen groups. So blood groups are inherited, and like anything with genetics, we have some similarities with other people, but we also have differences, and blood groups are no different. When a patient has a red cell transfusion, blood is usually selected for transfusion according to the blood group of the donor and the blood group of the patient. And we normally always match for ABO and RHD. So a patient may form an antibody against an antigen if the red cells of the donor have an antigen that is foreign or different to that of the patient. So antibody formation can cause problems with future transfusions. They can result in what we call transfusion reactions, and these can be severe and sometimes fatal. So there's a risk of antibody formation each time a patient is transfused a unit of red cells. So patients with conditions that require regular blood transfusions, like patients with sickle cell disease or thalassemia, are far more likely to form antibodies than patients who only receive occasional transfusions or one-off transfusions. So blood transfusion testing used to identify the blood groups can be split into two categories. So we've got serological testing and genotyping. So serology is a method that uses antibodies to identify these antigens or markers on the red cells. And this forms the bulk of all transfusion testing for both donors and patients. So the tests routinely performed are, as you've heard from Rachel previously, is a group and screen. We do RH and K types, and this looks at the C, the D, and the K, as you can see on this image. And finally, we also have an extended phenotype that looks at many, but not all of the antigens that are on the image above. So these tests performed on patients and donor samples. However, at present, only 1 in 6 NHSBT donors has a full extended phenotype. These serology tests tend to be manual at this level, and they tend to be time consuming and expensive. And often we can't easily extend them for many other blood groups. So that's where genotyping comes in. So genotyping differs because it's detecting the DNA sequence that codes for the marker on the red cells. And it's helpful when patients have recently been transfused, but also genotyping can provide us with detailed information or more detailed information than a phenotype. As you can see from this slide, there is a lot more antibodies or antigens, sorry, that genotyping can pick up. And using the correct platform, genotyping has the potential to reduce the cost per test, provide us with more information, and increase the speed at which we get these results, often through high throughput testing. So currently genotyping isn't performed routinely for donors, but we do perform genotyping on some of our patients, and mainly for those patients who are more likely to develop antibodies, so patients with sickle cell disease or thalassemia. In an ideal world, we would genotype both donor samples and patient samples on every sample that comes in to find the correct donor for the patient. However, that's not the case right now. And if we did that, we would massively reduce the risk of antibody production and massively reduce the risk of subsequent transfusions. There is a large piece of work, however, that is currently being undertaken in the UK called Heme Match, and this aims to do precisely what I've just mentioned. So, in summary, red cell transfusions can be life-saving for patients, but antibody formation remains a key challenge, particularly for patients needing regular transfusions, such as those with sickle cell disease. By moving beyond traditional serological testing to molecular genotyping, we can identify blood groups more accurately and match donors to patients more precisely. And it's projects like Heme Match that are paving the way for the future that enables the right blood to be given to the right patient every time.